the prostate gland and benign prostatic hyperplasia, BPH. It's a very common disorder. Men, of course, because only men have the prostate gland, or at least functionally, and they suffer from it. And it's a very common disorder, like I say. So what is the prostate gland? What does it do? Where does it sit? Anatomically, where it's found, rather. And what is BPH? How do we investigate for it clinically, and how do we manage it, and how does the medication work? So the prostate gland, it's a gland. All glands secrete substances. The gland sits just beneath the bladder. Now, if you imagine the bladder as a triangle, except flip it over so it's upside down, at the point of that triangle, imagine a pipe coming out. That pipe is what we call the urethra. That pipe it runs inside through the penis, and it's responsible for the actual the path the path that urine takes to be excreted from the body. Okay, so the prostate gland sits directly beneath the point, the upside down triangle at the point, wrapping around the urethra, and that's really important to understand. The prostate gland, what does it do? It produces secretions that contribute to the formation of semen, and consequently that also therefore supplies nutrition for the sperm. Otherwise, what the prostate gland does is that it actually undergoes some level of contractility, and that contraction supports the expulsion of sperm during the ejaculation process. So the BPH typically affects men after 50 years of age, 50, 60 and 70. The older you get, and keep going, and the older you get, the higher the incidence. The benign prostatic hyperplasia, what does it mean? So hyperplasia refers to growth, so enlargement. Growth of cells, larger cells is hypertrophy. Enlargement or greater number of cells is hyperplasia. So we've got a greater number of cells in this situation. It's prostatic, so referring to the prostate, and benign. Now benign refers to neoplasm. Please don't get scared, that means cancerous growth. There are two types of cancers, benign and malignant. I've done a very short, brief video on that, just to remind ourselves. Benign is safe, relatively, and malignant is the one that metastasizes. So benign, you get benign growth all over the body. Neuromas, a growth on the nerve, a lipoma, a growth of lipid tissue, and so on and so forth. But we do monitor benign growth, different tissues growth at different rates, and the reason we monitor because there is a small possibility that it can become malignant. So by monitoring it, we can check for those malignancy or the changes that are in keeping with malignancy, and therefore surgically excise the growth. Okay, so if the prostate gland erupts around the urethra, and the urethra is responsible for the actual voiding, so the path the urine takes from the bladder to be excreted from the body, as the prostate grows and enlarges, rather, it's going to cause encroachment of the urethra. Now that means that patient is going to suffer from a weaker stream, okay, because as I say, the pipe is narrower, it's encroached. The other thing is causing an obstruction, therefore the patient's from hesitancy. Hesitancy means that they have difficulty starting to urinate. On the other end of that, they'll get dribbling, so at the end of their urination, what they'll do is it'll continue to dribble, so you get a few drops still falling out, and that's dribbling. If we consider as the prostate gland grows, as it enlarges, it's going to grow in all directions, so it's going to grow upwards as well. The bladder, just to remind ourselves, is nothing more than a vessel in which urine collects, and it's purely a muscle called the Detrusor Muscle, and as it grows, as it fills, it stretches, and it actually works on the principle of stretch reception. So just like our stomach, when we eat, we continue to eat until the stomach stretches sufficiently to say, right, I'm full now, so the message goes up to the satiety center. In this situation, the micturition reflex, the bladder fills, and it stretches sufficiently to say, right, I need to now go and empty the bladder, so you go to urinate. Well, as the prostate grows, it grows upwards as well. So the bladder is actually a little bit smaller, the space is a bit smaller, a bit like a gastric band concept. So therefore, you've got a smaller capacity that needs to be filled, which means it'll fill sooner. Therefore, the patient has to go to urinate more frequently, so increased frequency, which is what we call polyuria. And then what you also get, because of the obstruction and the faster filling, the obstruction also leads to some level of incomplete voiding. So the patient has a sensation that they have to keep going because they've still got urine there. That unfortunately causes nocturia, so having to go to urinate at night more frequently. Okay, so why does the prostate enlarge? Why do we get enlargement of the prostate rather? Is because in the younger years, below 50 years of age, the male has a higher testosterone to DHT ratio. DHT is what testosterone is converted to, dihydrotestosterone, and there's an enzyme that's responsible for this 5-alpha reductase. Now, as we age, so we had testosterone greater amounts than the DHT. As we age, that swaps over. And so now the DHT is responsible partially for the actual enlargement. So one of the mechanisms by which we actually control this, therefore, is using medication that will block this enzyme, and that's called Finasteride. So the Finasteride blocks the enzyme, less DHT produced, and therefore less growth of the actual prostate. Although the efficacy of this drug is somewhat questionable. It's therefore used more as an adjunct rather than a first-line treatment. While we're here, the second treatment and the more common treatment used under the current NICE guidelines in the UK are alpha blockers, so the likes of doxazosin 2 milligrams or 4 milligrams, or tamsulosin 400 micrograms is the most common dose. And these guys, what they do is the urethra, the pipe through which the urine comes out, it's got little receptors called alpha receptors in the smooth muscle. So alpha receptors, what you do is, if you block the alpha receptors, you cause relaxation of the smooth muscle, and if you get relaxation of the smooth muscle, the urethra will open a little, and in doing so, it'll enable flow of urine more readily and more easily, therefore addressing the symptoms that we discussed a moment ago. Investigations, typical investigations, everybody's heard of the PSA. So the PSA is a prostate-specific antigen. Now, the thing is, as we age, this actually, more of this is released in the body. And so there's no kind of fixed marker as to how much it should be. Guidelines and various references, but 50 years of age it's 3, 60 it's 4, and 70 years of age it's 5. So in excess of these figures you want to consider a raised PSA, but more importantly, again, this is unreliable on its own in its entirety, so we use a number of investigations, but the second most important one is a clinical examination, a per-rectal examination. So you will have to have your prostate examined, and of course the individual examining will talk you through all of that. So that, my friends, was the prostate, the anatomical location, or otherwise where it sits in the human body, enlargement of the prostate, which is BPH, and what that causes in terms of symptoms, how we investigate it very briefly in a clinical setting, and then how do we manage it and how the drugs work. I hope that was helpful. Please do like the video, share the video, and comment as ever. Thank you very much.